This panel is yet another initiative in our attempts to enhance ethics here at SBMI. My name is Nathan Carlin. I'm at the McGovern Center for Humanities and Ethics. One of the things I do around the Health Science Center here involves the Quality Enhancement Plan, and we tried to enhance ethics in all 6 schools of UTHealth. So some of the things that we've been doing here at SBMI involve the Brewsters. I think all or most of you know about the Brewsters or have encountered it. We have 3 courses on ethics related courses here. 2 of them are taught by Dr. Ishee here, the other by Dr. Fenton, a health security course. Just over a month ago, we brought in Dr. Ken Goodman at the University of Miami. He is the bioethics, the only bioethicist whose primary area of focus is on health informatics, and he has a new column on ethics and health informatics in the Cambridge Quarterly of Healthcare Ethics, one of the premier journals in bioethics. So if you have an interest in the area, please consider submitting to that column. I have a number of questions that I'll ask of the panel. I think all of you know Dr. Ishee and Dr. Vogler, both faculty here at SBMI. You may or may not know Dr. Claire Clark. She's a postdoctoral fellow at the McGovern Center for Humanities and Ethics. She's done a lecture here at the School of Biomedical Informatics, and she's recently accepted a tenure track position at the University of Kentucky Medical School. So we're all very happy for Claire. We're sad to see her go, but this will be a great panel. So I have a few questions for the panel, and then we can open it up for questions from the audience. So the first question, and anybody can jump in your view, what are the key ethics issues that face health informatics today?
Okay, so one of the things that I always think of, and it's kind of the thing that everyone kind of goes to first, is privacy and security, and then also from an ethical perspective, the kind of idea of privacy and autonomy of people versus societal benefit. So you see this, and this kind of goes down to some of the other questions we have of, should there be privacy? Where should from a policy and ethics standpoint, where should that line be of, providing someone autonomy and privacy of their health information versus the ability of society to possibly use that information for public good?
Where do you think you fall down on that scale about sharing data or keeping data private?
So I think that there are, due to the kind of historical issues surrounding data and privacy in the United States, especially around discrimination among people who have certain medical conditions that may be stigmatizing to them. I understand why that we need privacy. I guess the question then becomes, as we move forward and we want bigger and bigger, sets of data, we want more and more information, kind of setting that line. I think that we're doing an okay job right now with HIPAA and the state law on privacy and security of information. I know people either love it or hate it. I mean, it's not the best. I mean, there could always be improvement, but it's kind of hard to get that line correct. So I think we're doing okay. I mean, I think there's some ways we could improve
Sure. So. How do you two feel?
For me, one of the biggest issues has to do with research ethics and informed consent, right? So if anybody followed the big Facebook experiment that blew up last summer, that really illustrates what I see as being a central ethical dilemma. So on the one hand, when you think about informed consent, which is agreeing to be a subject in a research study, and what that has to do with research that's being done on social networks, or on, say, mobile health applications that are supposed to be gamifying healthy behaviors and might be encouraging people to track their exercise or their food or alcohol consumption or their emotions. There are kind of 2 issues. One is whether people even read the informed consent documents to begin with if you give it to them, right? Or people are just checking them off and not thinking about it. The second issue is a little subtler, and it's whether these types of technologies are sort of subtly coercive by design. And so when you poll a lot of people and you ask them, do they want to be giving away this information? The vast majority of people say no. But when you provide kind of Pavlovian conditioning to them, right? So in the form of like, lights or buzzers or badges, then they're likely to just give it away. So there's a way in which sort of that short-term gratification might be compromising people's actual sort of rational intention for what it is that they want to do, and maybe making them overlook or ignore some of the potential long-term harms that might be associated with giving away all of that information.
Sure. The areas that I have concern for is ownership, and I think that's a problem that's going to continue with what we call personal health records now, where actually the patient or the client actually possesses copies or of their record is a problem with ownership. The other thing is that all the data now is being stored in the cloud. So, and it is coercive because you're sitting trying to get admitted to the physician, and oftentimes sick or ill or in a hurry, and so you have the form. Well, do I want to read it? Do I want to fill it out? So in the moment, you go ahead and do that and just say, well, that's done, so that you move on and can get cared for. But where that data goes nowadays is continually being stored in the cloud somewhere in someone's bank of computers. And who has control of that is the other issue. So I think ownership and control are two things that in the future we're going to have to worry more about.
That's great. Yeah. Our next question, I think this is primarily directed towards Dr. Clark, is discussions about ethics in informatics tend to be future-oriented, but why is it important to study past technological developments?
Well, so I think that's directed at me because I'm trained in part as a medical historian, also as a behavioral scientist, but primarily as a medical historian. So that's what I do, is look at past examples. I think one reason why the past can sort of be instructive for contemporary debates is because it offers examples of how people or groups have negotiated issues that we're confronting now, and we don't have to imagine how we'll negotiate them in the future. There are actual records of types of deliberations that have taken place. So one example that I used in a course that I taught medical students had to do with the emergence of X-ray technology and its role in making the modern hospital. And so, when X-rays were introduced into hospitals, nobody really used them for 20 years. They were a curiosity, and it kind of took a while for physicians to embrace them and for them to be used as a diagnostic tool. And then once people recognized their utility, they figured out that they could bill for radiology, right? And they became a way to generate profit. So in preparation for this discussion, I went back and I looked at a medical journal from 1922 and the debates about what the ethics of the X-ray machine and what should be the role of the X-ray in the modern hospital. And the argument that was made was that radiology needed to be a medical profession. At the time, it wasn't clear whether the people running the X-ray machine needed to be physicians, or whether they could just be run by technicians, or whether they could be run by quack proprietors, right, from contracted out somewhere. And the argument that was made in this 1922 article was that it needed to be a department. It needed to be a department on par with surgery. The people running it needed to be doctors so that they would be subject to the same type of medical ethics that every other medical practitioner was. And you could draw a kind of analogy to all of the new technologies that we see emerging today, and what is their role, in the modern hospital or for modern healthcare providers. I think of predictive analytics, right? And so, should we have a department of predictive analytics that's only run by doctors because that data crunching is going to determine patient care and could determine diagnosis? Or should we contract it out to private companies? If we go back and look at the debates around the X-ray machine, you can see that the medical profession decided this was something that they wanted to own, and they didn't want it to be commercialized separately.
It's really interesting. I'd like to get some perspectives here from faculty at SBMI, specifically around, this is the only school of biomedical informatics in the country, right? That's right. And so in a way that kind of connects with this kind of political question from the 20s about establishing the field of radiology. And so the question is, I guess what I'm curious about, what are the pros and cons of having a separate school of biomedical informatics? And I know that you all have, thought a lot about this issue in kind of recent years. And I guess, let's be positive, I guess. What are the strengths about having a separate school of biomedical informatics?
Well, our school is an integrated program.
Yeah.
There are other programs for nursing and other courses that are available for other professions. I think the thing about the strength of our program is that we have both clinicians and we have the technical side people in the same classes. So what we try and do is to marry those things so that the clinical people can be exposed to the technical side, and the technicians then can also, so they have to learn a whole new vocabulary, and they have to learn a whole new set of skills. In one of the courses that we teach here, the intro course, is that's exactly what we do, is that we can have them in group situations where they can exchange information and work on projects, such as the projects that are here. So I think that's one of the strengths that we have.
Right.
And
the interprofessional component
yes,
is
exactly.
absolutely key, because you couldn't just open up another school of biomedical informatics independent of a health science center,
Right.
let alone the best, sort of biggest and best medical center in the world. So I think this school is in a unique position to contribute, I think, a lot of really unique and interesting intellectual kind of questions and trainings and so forth.
Just a comment about the use of X-rays. It's like any other technology, it has to be assimilated. And so they had to train a generation of physicians that could use the technology and before it could really actually be applied for any measure. And then the other thing is that there's a curve of assimilation of technology that is pretty standard. And so we have to look at any time that a new technology is introduced, then it takes time for that to get off the ground, and then that there's enough people that are actually practicing that. So.
Anything you'd like to add? No? Okay. We'll move on to the third question. This relates back to the Dr. Ishee's opening comments. This is about the right to privacy. So the right to privacy is a central debate in the ethics of medical and public health informatics. Many critics have argued that privacy, like chivalry, is dead. That, in other words, privacy is a dated concept that has outlived its usefulness. To what extent do you think that society will still value privacy by the end of the 21st century?
So I understand, because I know there's been research done showing that older individuals have this traditional sense of privacy, and younger individuals, will post everything on Facebook. And I do agree that, the society's kind of views are shifting on privacy. The concern I have and I'm going to take off my SBMI hat and put on my attorney hat for a second, is if we don't have privacy, and I know there's all sort, and I see this on a daily basis, what happens if you have some type of disease that's stigmatizing? So you have mental health issues, you have an STD, you have HIV, and there's no privacy, and you go in for, you go to try to apply for a job, and they find out you have this. Now, I understand that there's all sorts of labor and employment laws about, non-discrimination, but the key is that unless they come out and basically say, we're not going to hire you because you're bipolar, I mean, it's very difficult to prove that you didn't get hired because you have a mental illness. It's more, they'll come up with a reason, well, we had a much,
better
another
applicant.
candidate, it's better. So the concern I have is if you just do away with privacy totally, you're going to have issues. And the same thing with genetic information. I know we have GINA that's supposed to protect against discrimination in employment, but the question then becomes, unless there's, unless someone's frankly stupid enough to put an email down, we're not going to hire, Jonathan because he has a predisposition. No one's going to do that. I mean, there'll be some people who do that, but most people will be savvy enough not to, be smart enough not to put that in an email or have a paper trail. So I always worry about if, when people say, well, we don't need privacy, it's kind of dead. I mean, I just worry about the practical implications of that outside of a research base, but like for individuals in their day-to-day lives.
So privacy's here to stay.
I think so.
Yeah, sure.
Well, I just want to say, do we really think there is any privacy anymore? Just with the recent stuff of the movie industry being hit, and the guy that's in Russia who gave away all of the trades or the secrets about whatever. So I don't know, with the computer and where all the data are stored all over the world, there's always going to be someone who's going to try and
So you're saying to the extent that our lives are digital, they are not private.
Right.
Even though we want to try to protect it, there's going to be hackers out there. And
there is no privacy. Our government and the governments around the world have enough information that they can identify individuals and their activities most anywhere. Even walking the streets now with cameras and face recognition. So I question whether or not there is what we think of as we have historically thought about privacy.
so privacy is gone. We say privacy is here to stay. Privacy is gone. What do you think?
I have I fall somewhere in the middle, which after saying we should look to history and not to the future, I have concerns that, maybe privacy will live on, but that there will be disparity. It won't be something that everyone has access to. That privacy will become a kind of luxury good that some people are able to afford, and that most people will not have access to it.
Interesting.
And to me, that's a health disparities issue, because there have been all kinds of studies done that show that a lack of privacy, whether it's physical privacy or online privacy, psychological, that is associated with stressors that have, are measurable physiologically.
No, I agree with you. And I think that a burgeoning occupation or profession out there would be for people who would sell themselves providing you privacy and manipulating the electronic environment.
That's interesting, yeah.
Well, and you already see that currently with how privacy regulations are written now, because under HIPAA, if you pay totally out of pocket, you can basically have you can affirmatively tell your healthcare provider that you do not want them to share your PHI for any of the traditional things that HIPAA would allow you, the healthcare provider, to share it, like payment, treatment, or healthcare operations. So, and the reason why that was put in there, frankly, was because what is the one health service that most people don't want showing up on their insurance? It's mental health. So the whole idea behind it was that people who have the money, who can afford to pay for mental health services out of pocket, don't have to have that reported, to their health plan. And remember, most health plans in the U.S. are RISA plans, so that it's your employer, actually someone like even here at UT, someone in the employee benefits department here at UT has a list of everyone's claims run for the year and with their CPT and ICD-9 codes. They're not supposed to share it to make employment decisions, but it's already been, there's already some, that's basically the reason why they have that provision in HIPAA. So
That's interesting. That leads to Ken Goodman's talk. When Ken Goodman came and he gave 2 talks, one at the School of Public Health, then one here at SBMI, and he basically took a position that I think is pretty common in health informatics circles. One is health informatics folks tend to be sort of pro-data sharing, and public health people tend to be, let's share information for the good of the population. And that is the position that Ken Goodman was taking. He's sort of arguing against privacy, arguing for the social good, and for researchers, for the health of all of us. He's saying sharing data and health information is a good thing. We can learn more. And the analogy that he invoked was relating to vaccines. He said, if we take this community here and we all agree to get vaccines, and then I decide to sort of opt out, say I don't need to get the vaccine because you all are getting the vaccine. He says that in public health language would be called a freeloader. I am benefiting from the fact that all of you decided to opt in, and you took a minimal risk in getting the vaccine, but I did not incur that risk, but yet I'm yielding the benefit from you all taking the vaccine. And Ken Goodman is suggesting it's the same with health, PHI and health informatics, that whenever we opt out of not sharing our health information, we're holding medicine back, we're holding the health professions back, and we ultimately are getting more incomplete data. What do you all think of Goodman's sort of analogy and argument? Is it a fair analogy? Is it a good argument? Is it a bad argument?
I'm the contrarian, so I'll let someone else answer first. But.
Yeah.
well, I guess when you look at, I would play the devil's advocate on this, because my question is if someone is going to commercialize for profit some type of vaccine or some type of medical intervention using a individual patient's health information, or more importantly, especially if the data being used is for some rare condition that there's not that many people who have it, I guess the question would become if you're going to take the position that society should be able to benefit from that. The question then becomes, well, what about me? Like, should I get compensated? The drug manufacturer is going to make billions of dollars on this. Shouldn't I get something?
Sure.
And that's the question.
Yeah.
Should there be some type of? I guess the question would be, should they move to some type of compensation system where someone could get some money back? You don't want to have the doctor who commercialized it. Yes, they commercialized it, but should they get all the money? Should the pharmaceutical company get all the money, and should the patient get left in the dark, especially if they're they don't have any money, or they're in a lower socioeconomic bracket? So
Sure.
I agree with you 100%. Is that I don't think that my medical information should be taken and put into a data set which is sold to a drug company, so that they know how many doses of a medicine that they sell in a hospital or to a group practice.
Yep.
So I think there should be some compensation, and there should be, just like we have a review panel for research, we also should have some type of review panel that looks at the commercialization of that data.
Sure.
And there ought to be some not reward, but some value placed on that.
I think even if you got rid of the commercialization aspect of it, the analogy is not quite, like, I could think of a better public health analogy. And for me, that it would be less like vaccination and more like disease registries. So like, say, like registries for for newborns that have birth defects. So the reason why we have those registries is because so epidemiologists can look at them and they can determine, are there environmental toxins? Can we prevent them? Society as a whole benefits when we determine, hey, this area has environmental toxins and we need to deal with it. But the trade-off is that then you have all of these newborns who are basically, what critics of these registries argued was that they're branded for life as being defective, right? So that's the trade-off.
So we're
for
back
public
to
health.
stigma. It
Yeah.
seems like stigma seems to be the biggest concern. Yeah.
As far as freeloading, we already have a group of people who freeload on vaccinations now. And those are the ones that don't take them because of religious reasons.
Yeah.
So they opt out. But statistically, there's a point at where that if the general population is vaccinated, then that is also a protection for the people that are not. So it's an ethical issue about where is that point?
Sure.
And what do you do about that?
Yeah, you don't want it to go above a certain
Right.
percentage of the population, and you can tolerate
Yes.
maybe certain fringe views or something. Yeah, that's interesting. Yeah. Our last question, and then we'll open it up to the audience. The last question is, what do you think are the most important policy issues facing health informatics today?
So I have three, and they're not in any order. I think one is who's responsible when something goes wrong, and I'm just talking about from a policy and ethics standpoint, because with the rise of clinical decision support and the use of electronic health records, as healthcare practitioners become more and more, I don't want to say dependent, because I know that gets a lot of the healthcare practitioners mad because they went to school, medical school, nursing school, and they can exercise independent judgment. But as these tools become more available and they start helping the practitioner make decisions related to a patient's care, what happens when, and who's responsible when something's wrong with the software? And so I know traditionally you can always argue, well, it's the physician who's responsible because ultimately they exercise independent judgment. But I guess the question should be, should the software manufacturers also be liable? Because these systems aren't cheap. A large inpatient EHR could be $70, $100 million. I mean, this is big money, so it isn't like it's free and they're using it. So there's that question. One of the things that I see on a daily basis is getting large hospital systems to share data amongst each other, because they sometimes view their patient information as some type of proprietary information, and if they share it with a competitor hospital, that somehow they're giving away some type of competitive business intelligence, or I don't understand that, but that's the view that I've seen from certain institutions. And then finally, I think the role of informatics in kind of cost containment and paying for healthcare services. So, everyone wants to move from a fee-for-service model to kind of a pay-for-performance, pay-for-quality model. And I see informatics being very important in that, because how you measure the quality for the reimbursement. So.
Would anybody like to respond to anything or add your own policy?
Well, one thing is that policy grows out of experts who have knowledge in the area, plus the data that are available, and then that legislation then falls on policy being generated out of it. So I think that the problem now is that we have so much data and so many people involved in that health data, is ownership and also knowledge of that. So I think that in the policy making, then people who have backgrounds in health informatics should be included in that whole process, and I think that's important. And I don't see that happening at this point. I know that in the American Medical Informatics Association, I know personally some people that work in either for IBM or a government agency, and they have an informatics background. So I think we need more of those people in the whole system to make it work.
Sure. Yeah. Okay, we'll open it up for questions from the audience. Oh, yeah. Yeah. Yeah.
Hi, my name is Chaitanya. My question is specific to predictive analytics. We have now the trend where technology is able to use claims data or EHR data to actually go ahead and predict outcomes for a patient or a population subgroup or an entire catchment population for an organization. I mean, it sort of goes to the point that you were making about labeling people, and now we have the capacity to be able to label them in advance of actually something happening to them. So what do you think is, as somebody, let's say, oh, this person is just bound to develop heart disease or congestive cardiac failure down the line, even though this hasn't happened, but we have a statistical margin in which we can predict that happening. So what do you think is the ethical implication of this kind of predictive capability, which is based entirely on statistics?
Who wants to take that one? Nate, do you want to take it?
It's a really great question. As you know, some of the standard principles in bioethics that have been applied across discipline are autonomy, which we've talked a lot about with regard to privacy and confidentiality. But another one is beneficence, and that's what your question is relating to. And I mean, it seems to me that when it comes to something like heart disease or diabetes or a stroke, you know, things like that, it seems like if we can predict that with a very high level of confidence, it does seem to me that we would have some kind of obligation to inform the patient and the family members of these risks. Also because the risk of sort of revealing that information is very low. Now, if it comes to something like Huntington's disease, which if you're, in some cases you have a very high percentage of acquiring Huntington's disease if as high as a 50-50%, you can be born with it. If I think it's if just one parent has it, you have a 50-50 chance of having HD yourself. Now that it would see, even if we could, you know, and we could run tests to sort of for children to know if they will develop it later in life, to force that kind of information on somebody would seem wrong. And I think because the illness, you say, well, why is that the case? I think it's because in that case, the illness is so devastating, and at this point we can't cure Huntington's disease. Whereas with heart disease and diabetes and so forth, there's a lot of preventative measures that we can take. So I think if the effectiveness of our intervention is pretty high, I think therefore the higher our obligation goes with disclosing that information ahead of time. I don't know if anybody in the audience would like to respond to what I've said, disagree, or if any of you would like to say. Yeah, sure. Oh, yeah. 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 Mm. Yeah. Sure. And with schizophrenia, I know from the studies that I've looked at, that is maybe a closer example to HD. You know, you got high levels of stigma. It's a very devastating illness. But what we know about schizophrenia also is that the earlier the intervention, the better the lifelong outcome for a person. So again, in the cases of schizophrenia, I think it would be pretty crucial to have an early intervention as well. And I know that there's also some studies that have been suggesting that smoking marijuana at a young age seems to have some kind of association with developments of schizophrenia. So you would really want to, make sure your child is kind of being safe too. Would anybody else like to comment on this issue? Or?
I think it is beneficence. And just historically, the way that we treated lepers, isolated them, put them on islands, got them out of the public. But then we turned around and said, well, mentally ill people, locking them up in these buildings is against their rights. And so we've turned hundreds of thousands of them out into the streets without care. So society in general, based upon religious values and their degree of beliefs about beneficence or the good of everyone, changes from time to time. So I think it's a major problem, is that when you have information that can harm a person as far as their livelihood, success in society, and being part of that, then that's the question that we're going to have to do. Historically, we've said that it wasn't right to do autopsies on people. And now we say, well, if we don't do that, then we haven't gained more knowledge to make good decisions with. So it's going to be a balancing point, and I think it's going to go back and forth before we arrive at some.
Yeah.
Hello, my name is Anna Shu. I would like to first bring up one issue, is that for at least smokers, I believe MD Anderson has a policy of not hiring people who smoke due to the carcinogens that may be affecting patients. But I also do know some smokers who deliberately do not seek treatments, smoking cessation interventions from their physician, because they know it will be put on their record, which may be accessed by MD Anderson. And so it's already one of those things that affects employment. So it doesn't need to be a theoretical thing about schizophrenia or bipolar disease. I have a question about medical information that isn't confined to the EHR. So there's this company called 23andMe, which you can swab your cheek, send them your genetic information, and then they will give you some information about your ancestry. And until recently, until the FDA stopped them, they would also give you some information about your possible chances for various diseases. That information isn't passed through an IRB board or a research ethics panel. They simply take your information, your genetic information, which is linked to your name, your credit card information, your address, and it's freely sold to anyone who wishes to purchase it. There are Silicon Valley startups, people on Facebook, whoever has the money can purchase that. And a lot of these companies, they do charge for these services, but the main value is the collection of people's genomic information. And my question is, do you think that should be regulated, or should it just be the current policy, which is like Facebook, is, well, whoever puts up the information, it's their fault if they put it up for public viewing, and they just have to deal with it?
So I think this goes back to your original comment about consent. I mean, I think part of the problem that a lot of the 23andMe's, the Ancestry.com DNA test, all these people are coming out with DNA tests, and you're right, the reason why they're not cost prohibitive is because they're basically charging a upfront fee to the person who wants a test, but then they're making the money on the back end by selling the information. And I guess the question then becomes, from a consent standpoint, when people buy the test and do the test, are they aware of the fact that this information is going to be sold to third parties? And I know you're shaking your head because you're right, like traditionally it's not, it's either in really small type where they have their in-house attorney draft up like a 15-page use agreement, and it's stuck in like page 7, and no one reads those. And so I guess the question is, I think the first question is if they would make it so that people understand what they're doing. I think I personally would have less of an issue if you knew in no uncertain terms that if you take this genetic test, your information will be sold to a third party. I guess that's my big issue. And then you can talk about, well, do the people actually really understand what that means long term, or those types of things. But I think the threshold would be, do they know what they're getting themselves into? Because there's a website out there called Patients Like Me that basically was designed to people with rare conditions could go on, upload their medical information. The whole idea was that you could connect with other people with rare conditions and talk about treatment plans. And if you go to the Patients Like Me website now, it's better than it was, but at least you if you read the whole privacy statement, it does make reference to the fact that they will sell certain information to third-party pharmaceutical research. I can tell you, if I'm correct, if I remember correctly, when Patients Like Me the website first came out, I think they were much less, in my opinion, transparent about what they were doing. And so once again, it kind of gets back to the consent issue. You're thinking you're going to do this. I mean, most people understand nothing in life's free, but putting that aside, you're thinking you're uploading, maybe you're desperate, you have a rare condition, you want trying to find out what you can do, try to find out a specialist in other parts of the country, try to connect with other patients with the condition, and so you're kind of overlooking that and just uploading things. So I think it gets back to the consent issue.